The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by independent educational grants from AstraZeneca and Johnson & Johnson.
Hello, and welcome to another episode of the AUA University podcast. I'm your host, Dr. Mark Gonzalgo, professor of urology at the University of Miami and chair of the AUA Office of Education. Today, we're tackling a topic that every practicing urologist encounters on a routine basis, the rapidly evolving treatment landscape for non-muscle invasive bladder cancer. Over the next several minutes, we'll walk through updated risk stratification, best practices for BCG implementation, the expanding array of immunotherapies and gene-based treatments, and real-world considerations that shape how we deliver these therapies safely and effectively. And I'm very pleased to welcome our guest today, Dr. Janet Kukreja, Director of Urologic Oncology at the University of Colorado. Many of you already know Dr. Kukreja through her contributions to the bladder cancer literature and her leadership in clinical trials shaping how we manage high-risk disease. She's been at the forefront of evaluating new intravesical and gene-based therapies and has played a key role in translating emerging evidence into practical guidance for everyday urologic practice. Janet, we're delighted to have you with us and look forward to your insights.
Thank you for having me.
So let's start with the basics, kind of to frame the discussion. Can you walk us through the AUA risk stratification system and why it still matters going on 2026?
Yeah, that's a good question. So I think the AUA really put a lot of thought, and I would just like to preface like the guidelines and sitting on the guidelines panel, how these guidelines are made are actually, they're very well done. They're very well put together. They're very thoughtful, and they're a little bit unique in the sense that the loudest person in the room doesn't necessarily get what they want in the guidelines. It's very evidence-based. And so the AUA guidelines, I think, are the backbone of how most urologists in the United States manage bladder cancer. And this low, intermediate, and high risk is different if you look across different guidelines. But the AUA guidelines have the low risk, which is essentially like your low grade one, like your first one that you see. It's small, solitary, kind of those initial bladder cancer diagnoses. And then a lot of patients that have low grade disease do move into intermediate risk. They have a recurrence of our low grade, sometimes it's multifocal. Some of the small high grades fall in the intermediate risk too, and then the high risk. And I think that's a lot of what we're going to be talking about today is these high risk bladder cancers. So bladder cancer that's a CIS, a large TA, or any T1 high grades.
Great. And before we get into specific regimens, can you give us a high-level overview of the current treatment toolbox for non-muscle invasive bladder cancer, from BCG and intravesical chemotherapy to gene therapy and perhaps some systemic options?
Yeah, so for those patients that fall in the high risk category, there are a few patients that have some features that are tricky and sometimes managed best by upfront cystectomy. Like lymphovascular invasion, micropapillary disease, some of those variant histologies that are quite aggressive. And the reason that we often offer upfront cystectomy, just to kind of get that out of the way, is because a lot of times what I'm going to talk about today is not enough for those patients. Like it can't get on top of those cancer cells. So some of like very broad overview is so we have BCG, which is like the traditional original immunotherapy given locally in the bladder. We have combination chemotherapies and chemotherapies given alone, and new formulations of these chemotherapies formulated in ways to hopefully be more effective. And then we have gene therapy, which is the nadofaragene, as well as a systemic immune therapy, and most recently, combination of BCG plus systemic immunotherapy.
Great. You mentioned BCG. Obviously, that's one of the mainstays of treatment for non-muscle invasive bladder cancer. And, we're going to focus now perhaps on implementing that according to AUA guidelines. And we all use it, but we know that practice variation exists and shortages of BCG make this a moving target. Can you walk us through guideline-based implementation of BCG treatment?
Yeah, so I think the guidelines are somewhat loose, and it's a little tricky because a lot of urologists don't have access to anything except BCG. So, some patients that come in that have like a bigger low grade might get BCG, stuff like that. But guidelines based would really be for those high risk patients, and especially in the setting of BCG shortage, really focusing on the patients that have TA high grade, T1 high grade, and CIS. For any patient that has the high risk, high grade disease, usually recommended to do 3 years. And so most people use the 6 weeks of induction, cysto, 3 weeks of maintenance, and then cysto every 3 months, and then, doing maintenance throughout 3 years. For some of the, intermediate risk, so a high grade tumor, but it's smaller, a lot of people will do 1 year of maintenance. And so I think during the BCG shortage, it never really became officially part of guidelines, but there was guidance put out about how to manage and split files and who to skip maintenance on and stuff like that. And so I think we really tried to take a limited resource and focus it towards these high risk patients.
Great. And it's interesting in the era of BCG shortage, which hopefully will be passed with the opening of the new facility. A lot of patients may be concerned about, partial dosing or not getting as much as they're supposed to. For the audience, how do you talk to patients about partial dosing, and perhaps how do you triage who gets full strength versus partial?
So the only patients that we had getting full strength were patients that were on the Bridge clinical trial, because it was required for that. Everybody else gets triaged to half or third dose depending on what we had available at the time. I went to great lengths working with our distributors, Cardinal, trying to up our vials. We were growing practice, and so just trying to navigate those things and having the meetings with the people and stuff like that. And that's what I tell patients. I say, look, I have done everything that I can. If you can find somebody else to give you more, that's okay. Like I'm not offended if you want to go see somebody else for more, but this is all I can offer you here.
Right. And it's about patient reassurance, and, you can perhaps even reference the data for partial dosing. And I think that goes a long way. But, for practices that are perhaps still facing BCG scarcity, or even for patients who simply can't tolerate it, what are you reaching for first?
Yeah, that's a great question. So it depends on the patient's profile. Like if I can get them in a clinical trial, I get them on clinical trial. If the patient is not a candidate for any of the clinical trials I have open, a lot of times I'll do combination gemcitabine docetaxel as an induction and then maintenance protocol.
Great. This is going to be an interesting part of the podcast because I want to kind of fire at you 4 or 5 clinical scenarios, with the focus of trying to individualize patient care. So I'm going to throw at you, say you have a patient with intermediate risk disease with large recurrent tumors. What's your strategy for those types of patients? Again, intermediate risk with large recurrent tumors.
Yeah, if they've never been treated before, often I'll offer them depending on kind of like their situation, I'll offer them gemcitabine and docetaxel in combination, or gemcitabine alone, or mitomycin alone. A lot of the times, like I'll try to save mitomycin after somebody has a recurrence after gemcitabine docetaxel or gemcitabine alone. And it just kind of depends on how aggressive they want to be. Gemcitabine alone is really easy to do in the office. Like you put it in, they go home. The gem-dosi takes a lot more time in the office, and it's a little bit more of a commitment. So it just is kind of how aggressive the patient wants to be.
Got it. And what about for that high risk patient, perhaps a patient with CIS only versus papillary disease?
I think for the CIS only, I really do try to triage them to BCG. But with the Bridge trial, we enrolled, several patients that were CIS only that got gemcitabine docetaxel as well. Papillary disease, it kind of depends on, the size of the papillary disease, but papillary disease only, often I'll talk to them about BCG. If I have BCG, like that would be first line. If we are kind of running out of BCG, I do think that those patients can also benefit from gemcitabine and docetaxel.
Great. What about immunosuppressed patients?
Yeah, immunosuppressed patients are really tricky. It says in the guidelines if the patient's on a TNF alpha blocker, BCG is an absolute no. And like if something bad happens while an immunosuppressed patient is on BCG, like we can be seeing lawyers, and that's not anything that we like. I think it is very reasonable for those patients to get gemcitabine and docetaxel upfront if they are severely immunosuppressed. I think, the patients that I think about a lot of times are the ones that could not stop their medication. So like liver transplant patients, like they have a liver transplant, they get BCGosis, like they can't stop their medicine, right? They'll lose their liver if they stop their medicine. So those are patients that I often triage to, more of the chemo intravesical treatments.
Right. And, we all see frail or elderly patients, or maybe those patients who are really sick. They have a lot of medical comorbidities. What's your strategy for those patients?
Yeah, I mean, it depends on their underlying disease, but sometimes less is more. So that may be a intermediate risk patient where I would say, well, the guidelines still say that it's acceptable to do a cysto in 3 months and then 6 months after that, especially if they're elderly and frail, if it's a low grade tumor. If it's a high grade tumor, I think like risk versus benefits. And truthfully, a lot of those patients do still tolerate BCG just fine. Like we have this concept that BCG can be really hard, but sometimes older patients, their immune systems are just not as active. So they don't have those same responses that the younger patients have where it's harder to tolerate.
And we've all seen these patients. We give them BCG, they fail. The tumors are coming back, and they end up with this label, or we will call them BCG unresponsive. Do you have any words of advice or practical considerations when we start thinking that a patient is BCG unresponsive versus perhaps what we strictly say in the clinical trial definitions?
Yeah, I think that the baseline for the CIS, make sure that everybody gets at least one course of maintenance to say that the BCG is not working. And then you have those patients that have kind of these bad actors, high grade tumors. So they have a T1 high grade, the repeat resection patient has like a small focus of TA high grade, and then they get BCG induction, and all of a sudden, 3 months later, they have another tumor. Like those are patients that you kind of like send up your spidey senses a little. You're like, well, this patient is actually really BCG unresponsive. And so those are the patients that we want to catch, but we also want to make sure that we expose them to BCG properly so that they can go on clinical trials and they do get the full benefit of, the BCG and the kind of reminders to the immune system to try and fight this cancer.
Right. So I want to focus now on kind of new therapies, those newly approved treatments in non-muscle invasive bladder cancer. And we know now that, in some words, the gene therapy era for non-muscle invasive bladder cancer is here. Can you break this down for our listening audience?
Yeah, so there is a couple of medicines, like the true gene therapy is the nadofaragene. So this is for that group that we literally just discussed, the CIS and papillary tumors that are BCG unresponsive. And so what this does is it delivers an interferon alpha like directly into the cell. And it basically causes the cell to apoptose and then activates natural killer cells and kind of basically says, hey, immune system, like, look what we have here, to be like an anti-cancer cytokine. So kind of a little bit of a backdoor into the immune system. Gene therapy sounds really fancy, but it's kind of just a backdoor into tricking the immune system into doing what it should be doing anyway.
Great. And with so many new agents, how do we as clinicians choose between them? I mean, where does, for example, even pembrolizumab still fit?
Yeah, I think that's an excellent question. I don't know that I know the answer for that. We in the last year got in Lexo as well. And so I think, where I think the next like few years are going to be how do we sequence these, and what, like, are there patient specific factors that certain patients should get certain ones, or is it just kind of whatever you have on formulary, whatever their insurance covers, kind of what are the next steps and how we, sequence these? But like pembrolizumab, if you look at the data, like there are some serious consequences to pembrolizumab. What we're talking about here with the intravesical treatments, yeah, people get more urinary tract symptoms, urgency, frequency, burning when they pee. Like occasionally you have a bladder that scars and they get kind of an end stage bladder, but like the 15% immune side effects with pembrolizumab is real. And so, like, if you have 20% response at 2 years with pembrolizumab and you have a 25% response with nadofaragene at 2 years, but you have no systemic problems, you're not going to get type 1 diabetes, you're not going to, lose your colon, you know, it's just not a 0% chance. Like a lot of patients don't want to take that systemic pembrolizumab risks that they were willing to take when there was nothing else available.
I think that's a great point that you bring up. And for those of us who treat a lot of these patients, we've certainly seen the side effects and serious AEs that can be associated with the more systemic treatments.
Yeah.
One thing we also hear from practices is that, we want to offer these therapies, but how do we actually operationalize them? Again, for those of us in academic practice, we might have infrastructure and support that's there, but it may differ in those those practices that are more community based. Can you walk us through this at a high level of how they might be able to actually implement the strategy in clinic?
Yeah, I think it's interesting because I think everyone's like, oh, you're academic medicine, you have immediate access to everything. And I think the drug companies also have that idea that immediately I can just start giving it. And it doesn't work that way. Like I work at a cancer center, I have to apply, I have to show efficacy. Like if I want something on formulary sitting there, like I have to prove to them that like the cost is worth it. So it's not as easy as everybody thinks for academics. And then I think so I work in Colorado and I have several trainees that have gone to rural medicine and they're hospital employed, but they have small practices in rural Colorado. And sometimes the way that this can work for them is basically they buy the drug and then they bill the insurance. And if the insurance does not pay them, they're out, right? And so I think practically it has to be handled very similar to, I think, when a lot of the new prostate cancer drugs came on the scene, maybe about 10, 15 years ago, where they all had these prior auths and, forms that they had to fill out. And we're seeing a lot of that with some of these drugs. And so I think the first thing is making sure that your practice is not going to close because you're giving these drugs, and make sure that you have, you're prepared to handle the paperwork. And then I think it's just a lot of coordination with pharmacy, nursing, patient education teams. Fortunately, like while it's gene therapy and while it's chemotherapy, most of it is actually very easily handled and disposed of in the office, like the regular ways that we dispose of medications and stuff like that. So there's not a lot of extra that needs to be done with that, but there's definitely education. I would say that all of these companies have great education schemes where they'll come to the office, they'll bring you their product, they'll show you how to install it, they'll show you how to prepare it. And I would say that for a lot of practices, those resources are great. And then, counseling patients on what things are going to happen, right? If you have a gemdosi patient, counseling them that, hey, like you're going to be here for 3 hours, and making sure that they also understand that while these drugs are great, there are some caveats to them. You still have to stick to all the schedules, and, the dosing schedules are more favorable for some than others.
Yeah, I think that, for any group that is trying to implement these new therapies, you bring up a good example of the cost consideration. I've had situations where, we've scheduled patients and these drugs are expensive. And then for the last minute, one reason or another, they had to cancel. And, depending on the drug, a lot can go into the preparation of the drug. And essentially you've got a very large financial, commitment there for every patient. So I think these are real world, challenges that do exist.
Yeah, I would say if those things happen too, I have had that happen in the past. The companies sometimes will refund you or your practice. So do reach out to them and explain the situation. I had a very similar situation that where we had a Jelmyto prepared and the patient got admitted for a DVT at a hospital across town. And I was like trying to transfer him over and everything. And it just didn't work. It got wasted. And I told that story publicly, and the Tomato people reached out to me. They're like, "Why didn't you call us? We would have refunded you." And I was like, "Okay, all right, we're good." But I think these companies, like, they want us to use their products, and they understand that things happen, and so they are also a resource to us. They're a business, but they're also a resource.
Right. And so you made some great key points about implementation in the clinic. I don't know if you can follow that up with, once perhaps an intravesical treatment program is started, how we begin to build integration into practice, kind of building or strengthening that program, for practices that are looking to do that. I don't know if there are any essential infrastructure elements that you can comment on that are might be needed. Basically, what does a practice need to support the intravesical therapy program for success?
Yeah, I think like the first thing is making sure that your nurses are trained, like that you have like calling templates. So patient calls in and they have a fever. Okay, well you have to ask these questions like how high is the fever? Do you have lower urinary tract symptoms? Making sure that the nurses know how to triage those things, because when you're in the operating room, they're your eyes and ears, right? They're the people that are helping you with these patients day to day. I think the second thing is really making sure that you have like a schedule for the patient. So depending on what they're getting, so that they know like this is a 2-year commitment, right? Like you're gonna get maintenance for every month for 2 years, like, and these are where you need your cystos and stuff like that. Because it's not really like a dictatorship; it's a partnership, right? And so if they're out of town and they missed whatever dose, like we need to get it made up. And so I think it's good if you tell them up front, like, hey, here's your schedule. Here are things you need to watch out for. Here are things you need to call us for. These are the people you call. And then you make sure that the people that they're going to call are educated on and prepared to receive those calls. Like you want to catch the really bad things early, right? Somebody calls, they got BCG yesterday and they have a fever of 104 and they sound terrible. Like that patient is comes to the emergency room immediately.
Right. And we're going to get the side effects in a second. I want to, while we're on this particular topic, just want to ask you something that's practical for our listeners, because as more intravesical and systemic options become available, how do you approach sequencing therapies? Specifically determining how many lines are appropriate, when it's time to call it, right, and recommend cystectomy. I think that's always an option we bring up with the patients, but I repeatedly hear no, they're not ready yet, so we default to whatever we have, on the shelf that might be available. And finally, you mentioned it previously, where clinical trials fit into the decision-making process.
Yeah. So I think the clinical trial, which I think we were both a part of, getting the patient reported outcomes and actually getting the data around cystectomy and what we would call bladder sparing therapies, which is a lot of what we're talking about here. And it was, very surprising, I think, to most that cystectomy ended up being favorable in a lot of ways. But, as we're talking about here, there are very real parts to cancer care that sometimes we, maybe turn a blind eye to: financial toxicity, the anxiety, the skin anxiety, the cysto anxiety, all of those things. And so I'm usually very upfront with patients. And so depending on what they have, like if they have CIS, like we talk, like realistically, this is a really hard disease to treat. Like the minute I see them, realistically, this is something that we do not have the magic bullet for yet. We have a lot of things we can give you, but we need to be very conscious that at some point we're going to have to call it. At some point, we're going to have to say, like, cystectomy should be considered here. And by the way, it's not that terrible to have a cystectomy, right? Like, by the way, we seems like we maybe got better at it. I don't know, but bad things happen for sure. But like bad things can happen with a prostatectomy. Bad things can happen with a hydrocelectomy. Like there's always something that can happen. And so by and large, the cysto trial taught us that, maybe our perceptions were not necessarily reality. So I talk to patients about that. And then we usually kind of agree, like, we'll start with this, and then like we have this as a backup. And if we have a clinical trial open at that time, that would be the next step. If we don't, we should really talk about it again. And like each time there's a recurrence or a resistance or something like that, I address that with them and say, okay, where are you at? Like, how are you feeling? And it's really not just one thing, right? Like if they're having terrible lower urinary tract symptoms, they're getting up every 2 hours at night, stuff like that. I'm like, look, I could offer you this clinical trial. Like it would be great for me to enroll another patient, but truly you're miserable. Like, I think you would do better with a cystectomy. And there's some patients that literally are completely unfazed by the cancer, unfazed by anything that we give them, and they're fine. And I'm like, all right, well, I think you can go on to this. You don't have any really high risk features. I think we can, maybe do a BCG, maybe do an Inlexo, and kind of push them along and see if we can get a response.
Yeah, no, I think it's important to emphasize that this is a shared decision-making process with the patient. And, oftentimes I'll emphasize, what's more important, being alive and around, or succumbing to potentially metastatic disease. And as you pointed out, with the advancements that we've had with surgery, we can still maintain a very good quality of life with surgery. And in some cases, as you pointed out, the patients are more miserable because of their lower urinary tract symptoms or bladder symptoms, that they actually might be able to both have curative intent as well as improvement in the quality of life with surgery.
Yeah.
Before we wrap up, I did want to spend a moment trying to focus on recognizing and managing the side effects of treatment. When we're giving these intravesical therapies and patients may be receiving systemic therapies, what are the big things clinicians should watch for in terms of side effects? Everything from the usual post-instillation irritation to when BCG symptoms need escalation, to spotting perhaps even some early immune-related issues, where steroids might be needed.
Yeah, I think, it's very common, and we manage like the dysuria, frequency, urgency, low-grade fevers all the time. Like, right, like that's just BCG, post-surgery, like post-TURBT, like all those things are really normal. And I think the question is like, when are they severe enough? Like, we give them the oxybutynin, we give them the, myrbetriq, we give them the pyridium. Like, when are those things not working? When do we need to delay? When do we need to continue therapy? So, I mean, I am a big fan of sometimes giving patients a break if they're really having a hard time, like moving a week out, something like that. But I don't routinely check UAs when they come in. Like, usually we just kind of say, how you doing? And patients are generally very transparent. And like a lot of times they'll be like, yeah, they'll call maybe the day before, like, I just don't think I can do it this week. Like, I need a little more time to recover. And I don't know about you, but I see this in patients with BCG actually not during their induction, not during their maintenance, like their first or second maintenance. It kind of starts to wear on them more as they get later on in their maintenances. So just some things to consider with those.
Yeah, no, I agree. And, each of the treatments or therapies has their own unique side effect profile. BCG can be cumulative. It can affect patients differently at any point in their treatment, even throughout the maintenance period. So, Dr. Kukreja, thank you very much for sharing such an exceptional overview of where non-muscle invasive bladder cancer care stands. You really helped clarify not just the science, but also the practical realities of delivering these therapies safely and effectively. For more resources and educational programs, visit AUA University at auanet.org/university. I'm Dr. Mark Gonzalgo. Thank you for joining us. And as always, stay curious, stay compassionate, and keep advancing the art of urology.